To talk a little bit with the panel and with you about, so what do we do with this? Very powerful message, a lot of dialogue. I would say, if we don't fix this in 2013 and 14, we will have lost our shot. This is our time. So, to my immediate right, and it's really nice because I've known most of the panel for quite some time. Ophelia Garman-Brown who's a physician. She's Senior Vice President of Physician Services at Novant Health, and has been in this community for quite some time and probably needs no introduction. Likewise, Dave Cook, who I've known since residency, I guess. I was a young practitioner, he was in residency here. Is also Senior Vice President of Novant Health. He's founder of Lakeside Family Physicians up at the lake and has worked in primary care for many years. Glad to have him. Mike Doolin, who is Chair and Professor of Family Medicine in the CMC, one of our bright upcoming stars in medical research and education, and also a hometown boy, I guess, transplant, but went to residency here. And then, maybe not quite as, haven't known Bart quite as long, but we crossed paths quite a bit. Bart Walker's an attorney, originally from, I guess you trained at the University of Notre Dame, and Morehead Scholar at UNC, even though I'm a Wolfpack fan. Sorry. Yeah, we've had ups and downs, haven't we? But, and he's an attorney at McGuire Woods and specializing in healthcare law. So we've got an distinguished panel, and we'd like to kind of have some reactions and questions from the audience about many of the powerful messages in this film. And I'd like to frame it and say, so what do we do next? What's going to really change the healthcare system? One of the things I was struck by was it was a constant focus on really getting back to communications and treating the patient. It strikes me we spent decades of siloing healthcare and breaking pieces apart and becoming more business-like and more truncated, and therefore more chances for things not to go right with more and more moving parts. I think that was seen throughout this film. Dave, you got any thoughts on that?
Yeah, Alan, you're exactly right. I think healthcare has been so disintegrated over the past 3 decades. And one of the things somebody's heard me talk before is about integration of healthcare, and I think one of the saddest things to me, even in one's own practice, physician to physician, become disintegrated from the care that needs to be given to the patient. And then the patient himself are broken down into parts and pieces, and then their families and their social network are really almost ignored in their care. And I think one of the neat things, one of the things that CCNC is doing, and one of the things we're going to have to do is integrate healthcare from the physician to the nurse, to the caregivers, to the psychologist, to the ancillary, to the hospitals, the administrators, to the specialists, and not have such a fear of each other or a real discomfort in each other. I always say that if we took heart disease, or took the patient like we take heart disease, and put it in the middle of the room with the patient, with great science all around it, and the patient's care group around it, and said, okay, how can we compress the morbidity and mortality of this patient? How can we help them live to be 85 and die gracefully and peacefully in the right way? Instead of being sick from age 55 on with heart disease, stroke, diabetes, on multiple medications that not only bankrupt the system, but bankrupt their own household. And if we did that with an integrated group of folks, much like they're saying here, the answer, I think, in the pathway would be much different than we're doing so far. So, to me, that integration is a key.
I just want to add to that I think that one of the scenes in the movie where the administrator was sharing with the doctors what had to be done, it was very much a one-sided kind of conversation, and the determination of what had to be done was already there. And as David has mentioned, when we take away our focus and we give away our power, I think as physicians, that's a lot of what we've done. We've forgotten that we are physicians, that we are the persons who are administering the medicine. It can't happen without us. And we've, for some reason, given that away. And I would just encourage us to take it back. And not take it back in the way that it's us and them, because you've got wonderful administrators that are in medicine like Mary Hall and others who are doing a great job in administration and are one of us, if you will. So not saying us against them, but setting up the scenario where we can have an open and honest and transparent dialogue, and we all get to the same place, and that's making a difference in the lives of others.
Someone, when I first went into the administration, got in charge of Medicaid, somebody came and said, what's the most powerful medical instrument in the U.S.? Because doctors have to write and sign for everything that happens in healthcare. Everything we spend almost requires a doctor's order. And it's also the most powerful way to change the dynamic of what's going on now. You know, Mike, you've done a lot of work around really looking at the problem of the 80-20 rule that they referenced here, where there's a lot of we focus on hotspoters, right? Finding those people the most impactful that we can move to. Did anything ring in this thing that strikes us here in this community?
Oh yeah, definitely. I was very excited to see the Dartmouth Atlas referenced, and we have, when we look at Mecklenburg County, we see the same sort of variation in care, which is phenomenal. So if you look at access to primary care or access to the emergency department, there are threefold differences across the community. And a lot of that is related to socioeconomic status and or being disenfranchised from healthcare services. So I know as Anita and Woody know all too well that the patients that are underserved or have low socioeconomic status are more likely to not utilize the right services at the right time. If we can find solutions that help to identify the populations that are most at risk and then work to bring them in and provide the primary care services, I think we can make a huge difference. And one of the other things that struck me in the movie was seeing the people that came to the fair or to the event where they were providing free care. And it still shocks me that Mecklenburg County, with all the advances and the great healthcare systems we have here with CHS and Presbyterian and others, that we have this disenfranchised population, almost a city within our city, of people that don't have access to care. And they're getting outside the clinic. I know I'm speaking to the choir here, but when you go out into the community and you see this happen, it really is heart-wrenching, and it makes you want to do something to change the system and improve the ability for people to access primary care services.
Well, I also found it striking that in the film we saw the paradox between Safeway and all the healthy, pretty high-end opportunities they had, and then the family at home who were eating Vienna sausages. And the question is, what's the system that intervenes in that behalf? It's always intrigued me that we've lit so many fires. We've had great research projects. We've had a lot of things that have gone on, but we've never got them deployed in a way that's meaningful. And I've said many times, including in front of the same Senate panel, that it's the chicken or egg. Which you're going to fix first, the reimbursement or the delivery system? How do you change policy? Somebody's got to jump out there to start with, and there's this notion of disruptive collaboration, right? You may not have to change the organizational structure to get something done. I mean, that's the hallmark of community care. I mean, no one works for one entity. It's just a collaborative effort around a need, and you guys are the poster children for that. Can primary care medicine make a difference? If you apply it generally in the community, does it make a difference? I think so. Flat growth and $1 billion savings are, trying to get at problems one community at a time seems to work. So I'm going to go to Bart because he and I are probably the closest to the policy side. So how do we translate what we're doing and the successes we're getting, those escape fires, into real dialogue around that will lead to change? Because we had so many fits and starts around primary care payment, paying for things that we know make a difference, nutrition, and so how do we, you're in this community and you see some of the good things that are going on. How do we leverage that in policy debate in Raleigh and D.C.?
Sure. I've got a few different viewpoints on this. In my day job, I'm a healthcare lawyer. I work
mostly with healthcare providers, so I represent hospitals, physicians. So I'm more closely identified with that side of the equation. Views expressed here are not the views of any of my clients or my firm, which are my personal views, but to your point, I think at the end of the day, money talks, right? So to the extent you've got a successful paradigm that reduces costs and results in better coordination of care and better outcomes, I think sooner or later it's going to be rewarded. I think it only takes a few safe ways to catch people's attention. So I think the best selling point is obviously that. I think there's also something to the fact that you need to have your voice heard, right? I mean, you need to have your voice in Raleigh and in DC. And there's the one issue that I would take a little bit with the film's portrayal of institutional health care is that there's a tendency to demonize it. And I don't think that's entirely accurate. I truly do believe, more to Don Berwick's comments at the outset of the interview was, I think everyone of the business is really trying to do their best. They're just, they're reacting the way that they're supposed to react, and you can change what they're reacting to. Hospitals lobbying, not necessarily a bad thing. They're trying to caring for a lot of patients, same thing as physicians. Physicians lobbying are not necessarily a bad thing. I don't even think the national discussion has so much been about a lot of the topics in the movie. I think we'd all agree with a lot of that. I think most of the conversation has been about how to get from A to B and what the right mechanism, what the right lever to pull is to get that result. I think that solution is evolving. I think we're doing great things in the community. I think we're doing great things in the state. But it kind of remains to be seen. Not to be given too lawyerly an answer without really committing to one thing. That's kind of how
Well, I think that's always the problem when you're arguing for policy change, because you're never quite sure if it's the right, the outcome of it. And I know when people lobby for a new payment for something, and then you worry, well, if I approve that payment, will it suddenly start ginning up all these bills that didn't get me what I thought it would get, right? And so there's this natural hesitancy. But I think, the value of what this community and many around North Carolina are doing is rolling up their sleeves and saying we don't have to start with, how it's organized. We can get together and have a common mission on something and show results is extremely powerful around getting to, some of the points they have. And it's real easy these days to demonize. And I think at some point, quiet solutions tend to rise up and show results, and I think that's starting to happen, but it's accelerating. How about anybody from the audience that has comments on the film or thoughts of, or questions for the panelists or me?